Now, uh, some of you, some of you might be wondering how can I start a palliative care service in my region. So, Mr. Rontu Sangma is going to talk to us on organizing a palliative care service. And Rontu is the regional coordinator of northeastern region of Pallium, India, where the uh, and he is one of the member of state facilitation team, where they facilitate um, the formation of palliative care centers in different parts of India. And basically, he's a management professional with more than 16 years of experience in various fields. And he has been working in Pallium India for the last 4 years. And he believes um, working through non-profit organizations and by community organizing the community as well as mentoring, we can organize palliative care services. So welcome, Rontu, and it's over to you.
Thank you, sir, and good evening to everyone. And I also see some international participants we have. So good evening from India. I hope I'm audible.
Yes, you are.
Yeah, so like already Dr. Sunil sir have introduced, given my introduction. So I have been associated with Pallium for the past 4 years in palliative care. It has really been a beautiful journey for me. And like sir have said, I oversee this, the Northeast region. It has got 8 states and as well as West Bengal. So I'm one of the team from the state facility team. So we, as a division, state facility team, we try to get the take the work that Palliative India facilitate for access to palliative care, and this particular session is very important for you. That is how to take forward this palliative care service in your particular region. So in case you have any queries, any comments in between, like please to put in the chat box, or you can also ask directly. So so I'll go with a PPT. Let me just share it. Yeah. So today we are going to talk about organizational palliative care service. The settings will be different, compared to your regions. So here the first slide that they talk about the WHO palliative care advocacy triangle. So this is the book of law. You can say the guidelines. What are the 3 main components to setting up a successful palliative care services in your region? And that is education, drug availability, and policy and implementation. Now, when I talk about education, we have seen that there are a lot of lack of awareness among professionals, among the administrators, among the public also. So education plays a very major role in educating the public, and definitely public demand can always persuade the administrator. So to think about to having a palliative care in their particular state. Now, when I talk about drug availability, we all understand that pain relief is integral part in palliative care, and morphine is the mainstay in palliative care. So there was an amendment in of NDPS in 2014. But that will help the particular state, in related to patients suffering from serious health related. But unfortunately, most of the states have not implemented it. So that is some of the few drawbacks that that we have seen, and and policy and implementation. If you see at the palliative care services that has come across the in the states, most of them are started by individuals or NGOs. So, but to achieve this national coverage, palliative has to be palliative has to be should come into the three health layer system: the primary, the secondary, and the tertiary level. So and the government should help to remove barriers for access to pain relief. So it is very essential for budding services, especially those who wants to develop their own policy, that can help them come up with this kind of services that they want in their particular regions. Next slide, please. So in the Indian context, broadly, it is categorized into three categories. One is the standalone hospice or palliative care center. This standalone, as we understand, this is an independent entity, where they take care of the patient, who are in need of palliative care services, and so they can be this can be done through an hospice or a palliative care center, and in a department or a unit within the hospital. So this is like we have seen in some hospital, in government setups, they have a dedicated palliative care unit in the hospital. So for the palliative care patients. And charitable, as you know, that even Pallium India is a charitable organization, and sustainable for profit making also. For profit making, but various way they can run their way of running the services. For profit making, they can create the service and they can charge for it. But especially for charitable, they have to depend on CSR grants and all those donations. For government, they have various funds, but that's inflexible. That's through this NPPC or this Ayushman Bharat. So, and the community-based home care, which is very important. This is where the community gets involved. Here, the particular this particular home care services is right to their to the doorstep of their patient. So you can understand, this particular home care service, this acts as a bridge, in fact, for the micro and for and a macro level. And the major, you can say the major social capitals, these are all volunteers who takes care of this community based home care. And there's volunteers in their respective region. Next slide, please. These are few standalone hospitals that me and my colleague have visited. Since I take care of the Northeast region, so in Pune, this Cipla Foundation is there. So where my colleague takes care of that region. And on the right-hand side, you can see Ruba Abandra Hospice. That's in West Bengal that I visited. This is also an example of standalone, and one more from my colleague on the north side. So that's just a few pictures that we got that we just want to share with you. Next slide, please. This is a hospital in Arunachal Pradesh. This I visited. On the left-hand side, one lady is there, doctor. This is Dr. Tasi. They have set up a 4-bedded inpatient palliative care unit. This is a government setup, so it's been beautifully set up, and they have trained doctors, nurses, social workers also. Next slide. This is the competent level. Usually we see that we have this micro and macro. Most of the time we see that only. So micro we can say as a beneficiary, and macro is the tertiary hospital, big hospitals, and it's very difficult for this micro beneficiary to reach out to macro. So so the next component, next slide please. Meso. So this is what we call as a home-based care run by the community. So this is the perfect example of running a palliative care services in the region. But yeah, settings wise, it may not be easy because every region will have their own setting. But this is the right way of coming out with a palliative care service run by the communities. Next slide, please. This is a Kerala palliative care model. Next slide. This is a volunteer from Kerala. His name is Mr. K.N. Nair. He's an ex-serviceman, and his wife was under Pallium's care. So he was a thorough gentleman, and when his wife passed away, he became a volunteer for Pallium India, and he used to visit. He used to go for home visit with the teams of Pallium, and he's so much energetic. At the same time, also he loves to take responsibility in the sense like nobody had to tell him that you do this, you do that. He just does it from his heart, and the beneficiaries especially they used to contact him. They are very comfortable talking to him, and he takes their call almost every day, and that's how that makes him happy. Also at the same time, also the beneficiaries are very happy to interact with him. Next, this is actually I just wanted to show this as well because this is what we call the kind of service that a volunteer can give. Next slide, please. Yes, so these are 10-step approach for setting up a palliative care services. Now, the first one is to arrange funds. Before starting a palliative care center, it's very important to understand from where the fund will come. Like from the governments, you have this NPPC. Through them you can get through their various programs. Then you have this Ayushman Bharat through that also. But at the same time, also for private, I've already told because it's a profit making, so you can create the service and you can charge for it. And as usual for other organizations like the charitable, they can apply for grant and CSR thing, which we can also help you to avail that. And you have a recruit and train a team. Now, very important aspect is that to have a team. Now, what is the ideal way of going forward initially? You should have a trained doctor, you should have a trained nurse, you should have a trained social worker. So that's going forward. Later you can have others like other allied professionals like maybe pharmacists, dietitian, therapists. But as a basic thing, it's good to start with a doctor, nurse, and a social worker. So then you have this built-in infrastructure. So you might be thinking, how do we start? Because infrastructure, no, that is not something very costly or very expensive, or you have to build something very hi-fi or something like that. No, for an OP service outpatient, you just need to have an space. Just a space is enough where you have all the necessary medical equipments to start with. And for an IP service, definitely you need more than that. And for the home care, definitely for the home care, you will need a vehicle where you can go for home visit, where you can keep your medicines and other consumables. And as like for an inpatient, definitely you must have some kind of a furniture also basic equipments, and also it should be, there should be beds for the patients to avail that facility. And procure opioids. Uh, you know, to store, procure, and dispense opioids, we work on one thing called RMI, recognized medical institution. This is a lot of, it's a long process, in fact, in Northeast, I have worked with several organizations, private, because government are deemed institution, they don't need an RMI certificate. But with a private one, we help them with a lot of other supports in terms of documents, in terms of how to talk with the drugs controller and how to connect with them. And then, so, for opiate accessibility, and also to have that kind of license where they can then stock, then they can stock, they can procure, stock, and dispense opioids. And the fifth one, network building and established connects. Now, network buildings and established connects are very important, because when you especially we help with Palliative, like we help you to get connected with the local resources, local champions, so that you can build up connects with them, and you can understand the available resources and the support available, and they can help you, and they can give you a lot of insight into that. Now, create awareness. Creating awareness among the public is very important, as well as for a team. The reason is that what we have seen out here is, like, what getting awareness, that you get a lot of referrals. So that referrals help you to get more patients and other supports. So develop OP, I already told you, you don't need you just need a space, maybe classrooms, maybe school classrooms in a schools, college, something like that, with basic medical equipment to run an OP. And then you can initially start with maybe weekly once. It depends on your time management, and then gradually start with 2 days weekly, or maybe, or maybe for 4 or 5 days in a week. It depends. But we have seen in some organization in the government also, they started with just one day for palliative care patients only. And develop IP. Yeah, developing an IP, definitely, as I've told you, like, you will need beds for the patients. Then you need site lockers. So and few other essential medical things that you need to have an IP service in a region. Develop home care service, as I've already discussed. You will need one vehicle to go for the home visit, where all your team can be accommodated. At the same time, also, you can keep your other things, like medicines and other consumables. And involving volunteers, I think you must have understood why the volunteers are important, because when you go to a particular region, there are communities. So if you have volunteers among the communities, they can help you reach out to the patients, those who are in need of this service. And they can also help you also, how to go ahead to their place while going to the patient place. So in other ways, a lot of other help, so they can provide you with. Next slide, please. But it's just a flow. It's not very rigid, that you have to follow this particular step. But this all by very based on your settings. So then we have this strategy per financial delivery models. Now, now what we do is that with our service from the state facilitation, with the model that we already discussed, like government, then we have this charitable institute for profit making and sustainable. So we have this, the first one is the capacity building. So capacity building are the major part, actually, so that we are providing as an organization. We conduct a lot of workshop, we conduct orientation programs, we have foundation trainings, we have for various healthcare professionals, doctors, nurses, health workers. We have this training of the faculty, the UG curriculum. We have training and engagement for the volunteers and community. In the past, we had specialized training like COVID, then presently we have for field service populations. So, and in government, like we are also supporting and training CHO, NM, and the ASA workers. So that's how it works for capacity building. Ability of reports, ability of OPS, I've already told you. We support in getting the NDPS implemented. We create awareness for medical institute about the new RMI process with the state drugs controller. We try working with the NHM to get the opioids included in state essential drug list. Then we also do a lot of hand-holding of palliative care unit at district level, connecting local palliative care networks. We provide document assistance and support as well. And there's a particular, PIP, PIP the government calls it. It's program implementation plan. That is, there's a budget that they have to plan for the year. The government submit every year, respective state government. So, so that is very important, and we can also help in making this PIP while if you are in the government setup. So implementation of NVC, development of palliative care through Health and Wellness Center under Ayushman Bharat scheme. So Palliative India contributes towards developing a state palliative care policy as well. We do have regular a lot of connects with the regular connects with the Ministry of Health Affairs for developing the palliative care in the respective states. So human resources, as I've already told you, why it's important, because you must have a team. So without a team, it's very difficult to start this service. So we can help you. We can help you also, like build funds through donations and CRS and other grants. And the last one, if you see the implementation, monitoring, and evaluation. So in the process, like what we do is that in the Northeast, what we have done, we have an implementation team, comprising of doctors, nurses, and a coordinator. They visit the site in person, handhold the team through the process of setting up a palliative care services for a given period of time. Yeah, next slide. So these are the challenges that me and my colleague we found while working with the various respective state governments and especially with everyone. So on one side it is a common one, the other side is a government. So all sectors, if you just go through it, if you can read through it, so we have seen that there is unavailability of funds and human issues, which is quite common, and procurement of opioids want to play safe. So we have also seen that many a times, like personally, I have seen that sometimes few institutes don't want to go for this RMI certificate. They're still following up the all process of going through excise. But that's a problem because now it is all through this drugs controller that is happening for any kind of license RMI. So they don't want to go through it because once they go through it, then they become the authorized doctor for document maintenance, for keeping the morphine safe, for a lot of other things. So, but I think there's a right process, because for anything we do, we must always have a documented process in place. So that's very important. That's why we are trying to create more awareness among the healthcare professionals. So we have also seen inadequate knowledge related to palliative care. That is always true. We all know that. And amendments in the relevant rules. Because recently, I'll tell you, I just went to a state called Shillong in Meghalaya. So I met the assistant drug controller. So he was the main one actually for the state of Meghalaya. So I went and talked to him. With great difficulty, I got his appointment, and I spoke to him, and he told me that they already have an RMI certificate. So I was very happy because they already have, and so my job is done. It became easier. Then I just asked him if he can just show me that particular certificate. Then he showed me. It's not an RMI certificate actually. It's an old process that they have been following for so many years without any difficulty. So when I asked him, sir, like, this is the new process, so these are the documents, why don't you apply? He said that no, nobody from the from their top level have informed us to go through it, and we have been doing it for the past so many years, and we are okay with that. So anyway, we requested for an opiate workshop with them. They agreed readily, and then we had that. And in Meghalaya, there are 11 districts. What happened, the good thing is that for the first time in India, we had drugs inspector participate from all the districts of Meghalaya. So it went well. So I hope that this will further enhance their knowledge, and then we can work together in the future. And definitely, I'm sure in the near time, every private institute will have an RMI certificate. So limited trained human resource in palliative care, that's also quite common, you know that. Sometimes some of them, they say that it's not very lucrative business. Still there are a lot of them, they tell me that there is no profit in this business. So that's an one own way of looking at things. So mindset, a lost cause, no treatment or saving a life, because they think that it's about the end of life care. So there's nothing that there's nothing glorified in that. So again, the mindset. Government, we have seen that there's very limited budget for palliative care because it is put under flexible. So when it comes under flexible, it gets divided into geriatric palliative care. So some limited amount is available for palliative care. That also depends on the need of the state. So that's quite challenging. Medical colleges, private medical, dependent on state budget. No provision for palliative care in NPPC. That is also there, because there is lot of lack of awareness. At the same time, also the fund is not that much here. So palliative care not a priority among all programs. That yes, personally I have seen that, and for my state, Northeast states, very limited funds. There is always a communications gap between one official to another officials. That's quite common. So that's also becomes a hindrance for taking forward. So sometimes few of them are reluctant in collaborating with an NGO. So they think that no, we are not the ideal organization to go ahead with that. So they try to work with other help body. So my colleague, like they have a lot of challenges. This is the overall challenges that we face. That include my colleague. They have a lot of challenges corresponding with Central Ministry Delhi in all the union territories, and that's also quite a difficult with a government official getting an appointment, especially any kind of one-to-one or in virtual or it's always a tough job. So we have to keep on following up with that. And the one thing that I've understood my interacting with the government is that never give up. Keep up following up, and then it will work out. So it has worked out for me. So it will always work in the end. So and also there is conflicts among a lot of department and those things, and it really sometimes with these conflicts we also our way forward gets hold for time being. So we have to work with all this through all these hindrances. Next slide, please. This is the standard audit tool that we have. This is the self-audit evaluation tool, you can say. There are two parts. Part A is essential. Part B is desirable. So this is for you all. You can have this. This part A essential is for any palliative care services that or center they should abide by. And the desirable are the regular requirements in your setup. Next slide. So PLM in the model. So we work through DEF. We call it DEF: demonstrate, educate, and facilitate. So we have the demonstration part we have in Trivandrum in Kerala. Next slide, please. So this is the demonstration. So we have TIPS, Trivandrum Institute of Palliative Science, which is a WHO Collaboration Center for Training and Policy for Access to Pain Relief. So here demonstration is very important for us because this is where we reach out to to our stakeholders how to deliver palliative care services in their respective regions. So demonstration for us, it always happens in Trivandrum. We have a complete setup out here. Next slide, please. This is the national helpline, telehealth we have. So here, healthcare professionals can call, even the patient's family can call, and they will get, the support and the assistance that they need to comfort themselves and to or to enhance their knowledge. Next slide, please. So, so the demonstrate we have what I've already shared with you that we have TIPS in Trivandrum Institute of Palliative Science. So there, that's where we do the demonstration. Next slide. Next is education. So who do we train and educate? We train doctors, nurses. We have got various courses for all of them, allied healthcare professionals, volunteers. We also have for students, volunteers for school, colleges. We have a specialty program like R1 also, that is for palliative care beneficiaries. Then we have specialist course like RCPM. So all these details are there in our website. Whenever a course is about to be scheduled, it is put on our website. So you can all go through it and can register or enroll yourself. Next slide, please. So now we go to the last part, facilitate. Yeah, so if you see this one, the last one in blue on the right-hand side, national scala. The last one that I'm going to talk now is on the facilitate. So because we work on three models: demonstrate, educate, facilitate. Demonstrate, we are talking about TIPS in Trivandrum. Educate, we're talking about what kind of training courses, programs we offer, whether it is on-site, whether it is online programs. Now I'll share a little bit about the facilitate part. Next slide, please. So we are 4 regional coordinators for our respective region. So my friend, my colleague Rajendra Dutt, he takes care of the northern region. So he is based out of Uttarakhand, and he takes care of around 12 states in the Northeast region. So for me, I take care the Northeast region. So Northeast region, as you already know, that we have got 8 states out here, and including West Bengal. So I take care of 9 states. Next slide. So we also have a coordinator from the central. Many of you, Sunanda also. So she takes care of the central region, and we have a new joinee who have just recently joined, just 1 or 2 months back. He takes care of the southern region. Next slide. So all just a minute. Previous one. Yeah, all this context, you will get it on our website as well, and we can share with you also. So for any kind of specific region queries, you can always reach out to us. Next slide. So moving to the philosophy of state facilitation division, we aim palliative care into the mainstream healthcare. We're talking about the primary, secondary, and the tertiary healthcare. So what we do is that we catalyze new palliative center services with various institution, government, charitable, sustainable, for profit. So here we give end-to-end facilitation for catalyzing those particular center. So we also assist in open SLT by helping the institution getting RMI certificate. As I've told you, this is a long process. There are a lot of things to be understood also, and then there are a few forms and documents to be filled up. So which maybe the next session or later on you will have a session on opioid, which they will clearly explain to you what are the various way to to go forward. So annual palliative care learning in medical institute. So here, education, we know that plays a major role in delivering palliative care. So we try to work with medical institute to involve palliative care in their undergraduate curriculum for doctors. Like here, we work with the trainers. They then train the students in palliative care. And we recently, few months back, we had good numbers of doctors coming from various states and from institution, who have been trained. And so, so the next process that they will do is they train their students in their respective medical institute. So build up community engagement and voluntary mobilization. So we work with stakeholders to help them build community engagement and help them mobilize volunteers. Like in Pelham, India, we create awareness among the public, get similar-minded people also, they join us, and then they form like some kind of a link center, and these people, like these volunteers, the community, they take ownership for palliative care in their respective region. So the last one is to develop pain-free hospital by eliminating serious health-related suffering. So here we are in the nation, we can say in the budding stage now, because we are about to start this process. Like what happened is that when a hospital wants to make, or an institution wants to make themselves a pain-free hospital, so every patient who comes for treatment in the hospital, their pain is measured on a range of score from 1 to 10. So 1 being the lowest pain and 10 being the highest. So we are still, we can say, in the budding stage for us. So very shortly we'll be working on this as well. And next slide, please. So this is the national presence we had. So far, we have worked with 25 states and 4 union territories. It regards to training and facilitation. We work with various NHM, state drugs controller, and we have catalyzed 5 site palliative care training catalyzed, on-site foundation training. So we have a lot of on-site training. So we have like our team of experts, they go to those particular site and they train the healthcare professional there. Pain-free hospital, so far we had 2. One is in that we could catalyze. One is in Silchar in Kachar Cancer Hospital. The other one is in Uttarakhand. So faculty development program. So far, like we could reach out to 29 states, and so that it's happening. So the first batch is over. So palliative care center catalyzed, so far we could catalyze 98 sites across India, and the numbers are increasing. So we hope that we will be reaching out to more and more numbers. So Hamrahi sites, Hamrahi site 15 sites. So Hamrahi is a project, where we are working with APLI. So APLI is Australasian Palliative Link International. They mentor palliative care center across India. So as of today, the mentors of APLI have mentored 15 sites through their projects. So they do it in all the states where they are where they are where they feel they're interested. So opioid access facilities 16 site. We keep on doing that, so number keeps on increasing for us. So yeah, next I think we are done already. Thank you. So it was a very short presentation from my side. Thank you for your time. Thank you for your patience, and hope I could keep some clarity. If you have any comments, if you have any questions, or any queries, you can please let us know. You can comment here. You can talk to us right now. We are here to help and support you.
Thank you very much, Mr. Rontu. It was very informative, and all the aspects were covered. But I would like to know, what about the licensing of the firm? When you are starting your palliative care center, you have to get it authorized by the local authorities, the DMO office, the healthcare, this thing and all that. So how do you approach? Who should you approach for that? What is the basic step?
So like I told earlier, the government are deemed institution, deemed RMI institution. But when it comes to the private one, the only few criteria that they need to furnish is they must have a certificate, a doctor trained in palliative care. They should be certified. That they should also have this their institution this, what do you call this, the institution, the hospital when it was set up, so that should be there. And then also they should also then they should have a but the doctor should be MBBS.
Rondo, I think Dr. Nishad asked a different question, and what I understand is to start a palliative care center, what all licenses do we need to get from the government?
Yes.
So
Yes, sir.
for
Yes, sir.
applying, for getting that, you have to apply in the local self-government body. If it is in a panchayat, you have to apply to the panchayat. They have a format in which they will ask many details about who are the doctors, nurses, the registration number, how are you going to dispose the waste. So once you get all these licenses, you have to actually first apply for the waste disposal, because
Okay.
otherwise they won't give license from the local panchayat. So after that, you have to apply it to the local self-government body, and they will provide you with the permission to work as a palliative care unit. It is not only applicable in case of palliative care unit, but for any health institution, healthcare institution.
Okay, sir. Thank you. That is very clear. Thank you. Thank you.
Okay, thank you, sir, for taking.
Sir, there is one problem which I have seen practically in Kerala. The panchayat does give the certification, but I've seen a lot of palliative cares mushrooming here, especially after the COVID pandemic, where nurses are opening up palliative, the so-called palliative care, home care programs, and they are visiting hospitals with no proper supervision and no control, government body control. I mean, I asked many of them, they're not even aware that such a control should be there or would be there. I don't know whether there is any such control, because otherwise sometimes the patients do suffer with due to mismanagement, which I've seen in certain cases, and nobody's there who is supposed to be accountable for them, making them accountable for this. How do we regulate this this particular area of medical profession? Because a lot of people are doing it, and I don't think that the patients are getting the right due treatment or care sometimes without supervision.
Sir, Sunil sir, since this is a question from Kerala, would you like to take on?
Yes, there might be some problem in this, because we know that there are many people starting palliative care units, but we don't know the quality or the standards that they are maintaining. So for this, I think we need to have something in place by the government. Otherwise, we'll not be able to do that. But I think Rondo has shown a self-audit tool, but that's for self-audit.
So
But it is Yeah. So the so government is. I don't think government is doing
So
anything in that step.
what I've seen is that there are a lot of, what they call as geriatric care centers, which
Mm,
have come up recently. And
mm,
especially in Kerala, this is a problem now where old age people are left alone with no one to care because their children are abroad. So they have no problem for money. So, but the children don't have anybody to look after their parents. So they can go and put them in the such cares, thinking that they are getting the best of care. But
yeah.
unfortunately, I cannot name any names, but unfortunately, I've seen quite a few incidences where gross negligence has taken place and there is nobody to audit this or nobody to
Yeah.
supervise this. So this
I
is
can
a,
understand what you are talking.
yes, sir. So I think Pallium India should come forward and ask the government, because you got clout for with the government, you should ask the government to start regulating this area of medicine, because this is an emerging field of medicine which is
Mm.
becoming very important nowadays.
Yeah, actually, for palliative care, we have an apex body called the Indian Association of Palliative Care. So I think Palliative India as an organization can do something, but I think IAPC as the apex body, actually, they are also coming up with many audit tools, but that should be approved by the government. Then
Yes,
only
sir.
the problem will get solved.
Yes, sir. And I think
I
it is
hope,
high time it is taken with the
yeah,
government very seriously.
yeah.
Sir, I would like to ask one more question. What if you are associated with another hospital? For example, you are renting the first floor or the second floor of a hospital, and you are running your hospice care center there. Do you need a separate license for that? Or can you work
Uh,
under the license of the hospital itself?
So if that hospital has registered as a hospital, then
Yes.
the palliative care will be another department. So you probably will not need any license
Okay, sir. Thank you very much.
because that hospital already will have various licenses. So
Okay.
and they are just starting another department. That's all.
Okay. So thank
And
you. Thank
probably
you.
they might have to inform the local authority. That's all what I think need to be done.
Okay. So in case of any death or anything in the hospice care, should it be under the hospital or can we attest it in the palliative center's name?
No, I think you are working in that hospital, isn't it?
No, I
Palliative
was,
care is.
yes,
Uh,
I was planning to start it and I had many
okay,
options. So that is
yeah,
why I asked you.
okay. So if you are working in that hospital, the death would be registered under that hospital.
Hospital.
You
Okay.
have to actually send. There is a format for informing the death to the local self-government body, which you need
Yes.
to send to the local self-government body. It may be panchayat or municipality or corporation, depending on the locality of that center.
That is with the hospital stamp.
Yes.
Yes.
So we are actually working. We are also working in a rented hospital where we that hospital already has license. So uh, um, uh, so we just send the death intimation form to the local self government body, and they will provide you with the death certificate. Actually, to the family member.
Okay, sir. Thank you. Thank you very much.
I think Dr. Raju wants to speak.
Sir, good evening, sir. Sir, we are also working as a part of a medical college. We run the hospice independently, but it is part of a Gayatri Medical College. It is as if we are part of the college, sir. They will be giving an IP at the time of admission, and they will be reporting our admissions also in the statistics, and all mortalities are also will be registered by them. It is absolutely mandatory. Unless all our details are part of the medical records of the hospital, then we'll be having a lot of trouble. Either we have our own registration or we should be part of the hospital where we are working. Working with or associated with. So it's very important.
Sir,
Thank you, Dr. Raju.
hospice death is considered as a hospital death only, no, sir?
Yes, of course it should be.
So
Yeah,
form
Part of the
4,
hospital.
okay, form 4A only will be filling for that. That's it. It's
yeah,
for
the
the,
yellow form.
okay.
Anybody else want to ask any more questions? We do not have a case presentation today, isn't it? Sir Priya?
No, sir. No case
Okay.
presentation.
Anyone have any more query? Any comment to put?
Yes, Dr. Kavin Kumar.
So you are muted or your voice is not coming, sir. I believe your mic is not enabled. Can you just check your device? I can see that you are trying to talk, but if you're using a laptop, maybe you just check, you have to check the icon of mic in there and come back.
Yes,
Then
Dr. Raju. Dr. Nikhil.
Yeah. So as you talked about Ayushman Bharat scheme in the beginning, so I just wanted to ask, is palliative care covered in that Ayushman Bharat scheme?
Dr. Nikhil, as of now, Ayushman Bharat covers the IP facility, but no home care or outpatients.
Okay,
Maybe after some time it might come, but there are many other clauses in that Ayushman Bharat scheme. One of the clauses that the person should be MD or DND in palliative medicine to avail Ayushman Bharat, the treating doctor.
okay.
And the institution should be a tertiary institution. And we were able to make it also to provide to secondary institutions also. But the other qualification is something which by which most of the institutions in India will not be able to access Ayushman Bharat insurance scheme because we have only a couple of or maybe less than 50 people in MD or DND in palliative medicine.
Okay. And insurance schemes in general also don't cover, I think, palliative.
That is something which I am not very sure. Um, I think insurance schemes are not. I'm not very clear. Is there somebody who can talk about this? Dr. Raju, do you know anything about this?
No, sir, not exactly. I'm not aware, sir.
Okay. Yeah.
Okay, thank you. Sir.
As far as I know, private insurance don't cover it, sir.
Okay, sir.
Sure, sir. Dr. Kapal Shikli, we can of Cipla in Pune. We take Pune.
just adding to that, since Dr. Kamal had asked it, we do maintain at Pallium India, we do maintain a directory where we store and publish the data for collaborators with us. I think, Mr. Ron, you would be able to throw more light on our directory in the Pallium India website.
Yes, on our website, PLM website, if you just check on our directory, part, you can see all the centers that offering palliative care service in their respective states. So we have all the details here. You can see the doctor's name, their contact number, their email ID, and as well as whether they have morphine available or not. So there's a whole bunch of information that you get here. The most important thing that you have the contact number also. You can call them directly, and they can give you more information on that. So please do visit our website on Pallium India website, our directory on Pallium India website.
Just
that answers.
adding on to that, those participants, all the eligible participants who get certified in the foundation course, they have an option to go for hands-on training, further hands-on training in our collaborative centers nearby their location. So once this course is over and you feel that you want to pursue more education, you want to get more knowledge, you want to get practical exposure in palliative medicine, please do visit the directory. You will come to know which is the center which provides hands-on training very nearest you. We will also be publishing a list separately after this, all the sessions are over. And I have already shared the details of the regional coordinators in the chat, and it is also available in the website. So once you have decided to have an hands-on training, please do get in touch with the regional coordinators. They will be facilitating your hands-on training with the respective institute with certification.
Dr. Vidyacharan. Dr. Vidyacharan.
I think he also is facing the same difficulty.
We are unable to hear you. No.
Still you are not audible.
Please check your headphone or something.
Yeah.
And Dr. Ravikiran, yeah, please.
Good evening, sir. It's a wonderful presentation. I would like to know if you already have a palliative care unit in the hospital and we want to do home care services. So what are the foremost steps and how to proceed with the approach work for the home care? And second one is how to identify the volunteers in our sector. As region-based and state-wise, we have different set of opinions regarding the volunteers. So how can we empower and how can we have a strategy that to elicit the volunteerism among the people? So how could we do this? These are my two questions.
Rondo, would you like to take it?
I didn't get the first one. I'll take the second one. The volunteers. How do we go ahead?
So
with
he was
that?
asking that he has a palliative care unit inside the hospital. He wants to start a home care unit. How can they go about it? That was the first question.
Okay, sir. So for starting a home care service, definitely you will need a vehicle, because to go to any home services, you must need a vehicle, to cater to the patient service. So and then so that is one thing, because you already, I believe, have a trained team. So you all need a vehicle where you can visit them. So that is one thing that you need for a home visit, especially if you're going in the far-flung areas or a little bit further. And on the volunteers part, what we have seen is that what personally I have seen, I can say that I have seen that when I went to any institute or any particular community, the first thing that we have to do is that create awareness, create that kind of zeal, enthusiasm. What is palliative care? Because nobody knows about palliative care. We have to go that way. We have to start from the scratch. So we have to, through some local networks, we have to go and reach out to them. We have to create awareness in very simple layman terms. Tell them what is palliative care and how they can support us. So that is the first thing. And then once they get interested and once they become part of the awareness session, then pick up few of them, maybe, because many of them may not be interested, maybe 2-3 of you can pick up from the groups. So then you bring them for an more detailed program that we have in Palliative. We call it volunteer training program. So that is a 5 days training program we give virtually. And if they can go to Kerala and take this training, well and good, on-site also. But otherwise, we provide a 5 days training program that helps a lot. Plus, it's a certificate course. So these are some of the things that they should go through first initially, before they become before they understand the concept of it, because understand the concept is very important. Yeah, that is the first process. Thank you. Hope that answers.
Thank you, sir. Thank you.
Dr. Ravi, can I add something to what doctor has already said? Because
Yes, please.
I have started home care services in two tertiary level hospitals from scratch in my place. And so from my experience, I can say, if you're starting a home care from a hospital, it is easier because first of all, you might have an oncology department there where you can interact with the oncologist over there to make you part of the care for the patient, maybe halfway through or 3/4 of the way through when the stage 4 or stage 3 or advanced stage 3 has reached, so that the doctors will anticipate that nothing more can be done. And so if you integrate with the team and take care of the patient, then the patient can be seamlessly integrated into home care during the end of life care or towards the terminal care. That way you will have your patients, and the oncologist also will be much relieved, because at the end of the day, when they say that nothing more can be done and the patient is supposed to be sent home, most of the time the family gets devastated. So that will be a very seamless progression where you can get your patients for home care. At the same time, it will be a great help for the other doctors and the service for the patients. Secondly, you can interact with the other specialists also, where like cardiologists and nephrologists or pulmonologists, where they also have a terminal organ failure patients where nothing more can be done. And so sometimes instead of admitting them repeatedly into the ICUs, they will say, okay, take care of them in the house. So those patients are also can be transferred under your care in the home, and you can visit them regularly and take care of them in the houses, so that will also be a great relief for the patients, the families, as well as the doctors. This is what I have done, and it was a great success.
Wonderful, sir. Thank you.
Dr. Biju, what you just said, can that also work out for a family physician who can then tie up with the
Yes, madam.
oncologist?
But if you are writing morphine, then you have to have the FCPM certification at least. That's the only difference, because family physician cannot write morphine. So if you are certified for this, especially after this course, definitely you will be certified. Then there will be no problem at all. In fact, that will be
what certificate? Could you give me the full form?
The FCPM, that is the basic training for palliative care, or the one which we are doing now, fellowship. Once if you complete that, then you are certified to write morphine, because especially for stage 3 end of life care cancer patients, they would definitely need morphine, because at least 85% will be in pain, and so we will be treating pain more than anything else, and that's the only thing we can do at that stage, and that's the only thing they want also in those stages. So if you have to really give them good care, then pain is a very important thing which you have to manage mostly with morphine and other opioids. So that will be an important thing. So once you get your certification, that will be very easy.
So this
yeah.
This FCPM will make
yes,
me eligible, Dr.
Of course,
Sunil?
definitely. Yeah, yes, sir.
Dr. Dimple, where are you from? Which state?
I'm Mumbai, sir.
Okay. So FCPM for Kerala, drug controller has approved this course as eligible for prescribing opioids. And I know that a few candidates who has done FCPM from other states, they also got RMI license. So I think you should also get.
Yes, sir. That's right, sir. In one institute I know, he was trained from Palliative India virtually. So recently, a few months back, they got an RMI certificate. So because they just wanted to see his certificate that he's trained in palliative care.
Okay, Doctor.
Who should I be approaching in Mumbai for the RMI certificate?
I think the details. Ron, who is the coordinator?
Ma'am, yes, ma'am. It is there in a chat box. Like we have Sunanda Samal. She's a regional coordinator for the central region.
So on the website, I can get the
yes, ma'am.
number.
You can get in the website. Yes, ma'am.
Yeah,
because you just get in touch with her. Yes, she will guide you, ma'am.
Okay. Sunil sir, I don't think that there is a CCPM on-site training in anything in Mumbai. So please start something here.
Okay. Dr. Yadav has asked another question. Do we need a certification to prescribe if we are working at a medical college? Okay. So all the government institutions are deemed to be RMI as per the amended NDPS rule in 2014. So government institution actually doesn't require RMI status because they are deemed to be RMI. But there should be a person who will take care of the overall person in charge. That should be a doctor who will be accountable for all activities related to opioids. So that's all. Otherwise, opioids, RMI status, government institution doesn't need.
Hello.
So the certificate which we'll receive after this course, we can't practice with that one itself.
So this is Dr. Nikhil. You are doing foundation courses, isn't it?
Yes.
Yeah. So foundation course in palliative medicine that will give you the basic idea of palliative care. So this is the basic course. So after this, you can actually practice palliative medicine, but and you can also apply for RMI status. But there are a lot of things that we all need to learn regarding palliative medicine.
Right.
So there are different levels of approach, which is called generalist approach. Then maybe um, uh, who will integrate the practice principles of palliative care into their practice. Then there is specialized care. So we might be in the midway between those who are going to integrate and between specialist palliative medicine people.
And if we
And
do
there are
that,
two ways. Yeah.
if we do that hands-on training after this, then that is enough, or again there's more thing we should do.
You cannot call it as a specialist, but that will definitely help you to get a better idea.
Okay.
There are two ways by which you can actually get morphine and other essential narcotic drugs, that CNDs. One is from a personal point of view. If you are running a clinic of your own, you can actually apply for morphine on a personal basis. But the amount of morphine that you can keep it with you is very less. I think it is about 500 milligram or something. So 50 tablets of morphine you can. But if you are working with an institution, the institution can apply for ENDs as recognized medical institution, and then you will be able to stock all the essential narcotic drugs like morphine in any form, fentanyl in any form, methadone, codeine, oxycodone, hydrocodone. So these are the 6 essential narcotic drugs as per NDPS Amendment Act. So if you have the RMI status, you can stock all this ENDs.
Okay.
But we can prescribe morphine on our prescription pads as MBBS.
Yeah, a person with modern medicine can prescribe morphine or any other opioid. But the question is that from where you will get this medication. Suppose if you prescribe morphine, who will give morphine to the patient? It is not available in 99% of the pharmacies. Only a few pharmacies stock. Otherwise, it is available only in recognized medical institutions.
And suppose if we prescribe and the then patient can go to any big hospital and can get it there from our prescription or not? If we are aware of that.
Yeah, that's again a question, because if you prescribe and send it to Palliative India, if I don't know you, I am not bound to give morphine to the patient, because I don't know whether you are trained in palliative care,
Right.
whether the prescription is correct or not. So I'm not bound to give, but if you have a connection with somebody, then it would be possible, because that person would know you are trained in palliative care, you know how to manage.
Right.
Sir, also
So that means we have to stock it with ourselves only if we are doing home care.
It, that will depend on, I told you, either you can keep it as a personal, you can apply it as a person, but I told you that it will, you can stock only 50 tablets or something. But for home care, you would need more amount of morphine. So always better to apply as an RMI, recognized medical institution. And whenever you go for home care, you have to carry some of the morphine with you.
sir,
And
I
sir,
think
your global foundation course is once a year, or is it going to
It's
be?
it's once a year as of now. But maybe I'm not sure from next year or from after 2 years we might increase the number of courses.
Sir, with regard to the private institution, private hospitals, they usually don't cater to any other outside prescriptions, sir, because they have their own prescriptions now, which is actually approved by the drug controller, which has to be fulfilled by the doctor who is approved by the drug controller in that hospital. So they don't entertain other people's prescriptions. And also, as Madam was asking, for home care, we need to have a lot of morphine to be dispensed, because we give it to the patient's relatives to come and take it from the hospital. So we can't carry enough of such medicine. So it's always only through the prescription that we dispense.
Yeah, actually anybody can prescribe morphine or any other opioids, but the question is where would it
It's
be
not available.
available,
It's
or
not
who
available.
would give it to the patient?
Yeah,
That's
it's not
the
available.
question.
Yeah, that's because, as you said, sir, correctly, because it is a very huge responsibility on the doctor who is registered with the drug controller through the hospital, who is in charge of the number of tablets which we are dispensing. So if he cannot account for it, he'll be in deep trouble. That's why they are not able to dispense it.
Parul has asked a question: does an anesthetist without a palliative certification course can get an RMI? So the answer is, according to the NDPS Act, the doctor should have experience in pain medicine, and as of now, they do not tell how many days of um, uh, hands-on experience is needed, but that will depend on the state drug controller. He will decide how many days should we need. But as per previous NDPS Act, it was at least 10 days of experience in pain management is the qualification that is necessary for applying for RMA status.
Sir, for follow-up patients, if they don't bring the patient, only the attender comes, can we give a refill of morphine?
Yeah, as per actually the NDPS Act doesn't talk about anything, but we usually provide it to the caregiver. But it's also our duty to confirm that the patient is there, patient is living, because sometimes the caregiver will come and he will give the morphine to the patient, and this will go on, but we don't know what is happening. So it is also our duty to make sure that this is going to the right hand and to the right person.
Sir, and unused medicines, we'll have to take back from them.
Yeah, we actually ask the patient or caregiver to bring back all unused medicine, and we can enter it as our stock.
So one more doubt. After
Yeah.
how many days of expiry of morphine also can be utilized? Like, is the duration, or if like anything such that we need to dispose immediately, not to use or something like that?
Actually, I think the expiry of morphine tablet is after 2 years of manufacturing. So don't use after that, because that can cause problems. If some patient gives any complaint, then that will be a problem. Don't use it.
Okay. Thank you, sir.
And you cannot simply dispose the morphine and other essential narcotic drugs. You have to actually write a letter to the corresponding drug controller, and you have to destroy it in their presence only. They will tell how to destroy it. They will come to the institution and they will ask us how many number of tablets are there, take it, and they will show you how to dispose it. And then they have to sign it also.
Till they come and personally visit, we need to keep it at a store.
You have to keep it in the store.
Till they come and see.
Yeah.
Okay.
Yeah.
Okay.
Morphine injection ampules, the spent ampules have to be kept and given back to the drug controller before it is replaced. That is also there.
Dr. Biju, that was according to the previous act, but now it
It's not
doesn't. No.
Okay, oh, I didn't know this, because we still do that. That's why we.
And there are another way of getting injection morphine. It is by something called as ND3 license. It is you have to go through the excise department, and they will provide you with the injection morphine, injection fentanyl, and that's how many of the private hospitals get the injection morphine and all the other injectable opioids. And as per that law, you have to produce the empty ampules.
We get it from the drug controllers. We already give them the quota, and then they give us the.
Yeah. Dr. Karishma?
So the form for the oral morphine and IV morphine is different.
So if you have RMI status, you can get all the forms of any opioids with that RMI status.
So whenever the patient, the patient or relative, usually if it is a bedridden patient, comes back and asks for a refill because the medicine is over of morphine, so should we insist that they produce the previous prescription as proof?
So if you know that person is taking morphine, or if you were the person who prescribed the morphine for the first time, then there is no problem. Otherwise, if somebody comes and asks you for morphine, you have to verify. How do you know
no,
that?
sir. So what I'm saying is that the duration, like I don't know if those the tablets are genuinely over at that date. Like basically to correlate the date when he has taken it last.
Yeah, actually, you have to count the balance of the morphine, and then you count it. And it is usually better to ask the patient to bring all the used tablets, or the cover of the morphine or something to bring back. And you also calculate, suppose the patient is taking 5 milligram 4 hourly, that means patient would need 3 tablets per day. And so for 1 week, you need patient might have consumed 21 tablets, and you also add some SOS dose. So it would be 25. So you then see how much tablets you have dispensed. If you have dispensed only 30, then you ask them how much tablets are with you. There should be at least this much tablets with you. Where are those tablets? So this is something which we need to ensure.
Yes, sir, because usually these are patients who sneak in between, and they, it is we don't have even time to cross check anything. And they'll say they have forgotten the previous prescription, or it is destroyed or something. So there's no way you can cross check.
It is always be careful while.
You're muted, sir.
You should be careful while you dispense ENDs, essential narcotic drugs. It's our responsibility to make sure that this is they are using it properly.
Yes, thank you, sir.
Dr. Punita. Dr. Punita. You are muted.
Sir, regarding patches of fentanyl and buprenorphine, the same rules is good for that also.
So fentanyl is coming under essential narcotic drugs, but not buprenorphine. Buprenorphine is freely available in the pharmacies. So yeah, so fentanyl you have to keep the account, but buprenorphine anybody can prescribe, and the patient can get it from the nearest pharmacy.
Sir, and for regarding methadone, do we get tablets or syrup, sir?
So in case of methadone, we have both tablet as well as syrup. But it is always better to take tablets because if you prescribe the syrup, it contains 5 milligram in 1 ml, and you might write 1 ml TID, and the person who is giving this might think it is 1 milligram, and then will give 1 milligram, and vice versa also can happen. And if the dose is incorrect with methadone, that can produce severe toxicities. So you can keep 1 or 2 bottles of methadone, but mostly you have to manage the patient with tablets.
Sir, and if my hospital, they're asking me to identify 2 distributors for methadone so that they can get quotation and then order for it. With the current RMI, we can go for methadone, no, sir?
Yes, you can get methadone with the RMI status, and only one pharmaceuticals makes methadone in India. That is Rosan Pharmaceuticals.
Okay. Okay. So I can get both tablet and syrup, less number of syrups and more of tablets.
Yes.
Okay.
Dr. Raju?
Sir, just I would like to add on something for about the dispensing of morphine when the patient himself is not available, when we are giving it to a proxy.
Yes.
It is very important for all of us to realize that NDPS Act is very, very stringent. And if we run into any problem with the administration for any reason, maybe misunderstandings in the family or a complaint, then it only our documentation can actually keep us safe. As far as I know, the NDPS Act is very silent about dispensing the drugs to a proxy, whether we can do it for once or whether you can repeat it again without the presence of the patient. These are actually questions unanswered. I don't think any mention was made. So we need to be very, very cautious. And the foremost and fundamental thing is, unless we follow the patient, who is maybe at home, who may be at a distance, maybe by a phone or a WhatsApp call, unless we know that he still survives, unless we know that he's conscious, unless we know that he's taking the drug, just going on repeating the medication can prove to be very risky. It doesn't happen all the time, but once is enough. I think so. We have full responsibility, and we need to be very cautious about dispensing these drugs, particularly when we're not seeing the patient directly. No amount of caution is less. We need to be, as Dr. Sunil said, counting the drug and making a rough calculation of how much has been used is very important. But just being busy is not an excuse. It will be very difficult to answer a drug control authority, whether it's a drug inspector or anybody. They can really act very tough, and we'll have a tough time explaining to them. Thank you.
Yeah, thank you, Dr. Raju, for reiterating that. And there will be a doctor overall in charge. Suppose in a hospital there are many doctors prescribing morphine, but there will be one overall in charge who will be held responsible for these opioids. So he will be the answerable person. Yeah,
Sir, if a patient is in the village and the hospital located in the city and the patient's known, like like friends have come. We have seen the patient in the video call. We have talked symptoms, and then we need to send to a courier. So what is the process that the person who has come to take the medicine is a relative of someone in the village, and the video call was set up, and we talked to the patient also. Now the morphine has to be sent by a courier to the village where the patient is resides. So what are the problem, or is there anything fine that we can courier like this
So,
the morphine medication?
yeah, you cannot prescribe morphine for the first time if you are seeing a patient through the WhatsApp call. According to the Telemedicine Regulation Act, it cannot be done for the first time. But if you have already prescribed the patient just on morphine while the patient met you at your hospital, and then for follow-up his cousin or somebody came, then you can give the morphine with the cousin, and there is a form that need to be filled and need to be signed by that caregiver that he has received so much of morphine with you. So all these are needed as per NDPS Act.
We need documentation, sir, that the
Yeah, yeah.
courier reached to the village and they have received that letter of
That we cannot make sure that, but you can get it signed from the caregiver.
Sir, do you send to a courier, sir? Do you take that responsibility of sending the medicine, sir? Sunil, sir?
Yeah, we do send through courier to the patients.
Okay.
Because the NDPS Act doesn't say anything about how it should be dispensed.
Okay.
Okay, I think more doubts about the opioids will be cleared in the opioid availability session. Probably, I think Rajagopal sir will be answering your questions.
Sir, for up to 1 month, we can prescribe, sir, morphine.
So again, there is no such how long it should be prescribed, how long you can give. There is no such mention in NDPS Act. So it would be better if you can prescribe it for 2 weeks and ask the patient to come back. But if the patient is from far distance, then maybe 1 month can be prescribed. But it's all our responsibility to make sure that okay, this is done properly.
So if it is a government hospital with an RMI and if the drug is out of stock in that particular, the linked pharmacy or the hospital pharmacy, what is the rule for like where can you refer the patient with that same prescription? Should it be in the same district or can it be?
Nobody. I think you can see the directory and send the patient to the nearest RMI. But before sending the patient, I think it would be always better to call the that RMI institution and talk to the doctor in charge, and because they are not bound to give morphine if you send a prescription to a patient, because they don't know you. Who are you? Have you done any course? Do you have any experience? So it is always better to talk to them. So they have to register this patient as their patient at their institute, and then only they can provide morphine.
Okay, sir.
So as we know that single patient cannot take morphine from 2 different centers, no, sir? But if we don't have the can go to other center. And yes, sir.
Yeah, actually, the patient should not be taking morphine from 2 different centers. But here, the situation is different. The morphine is out of stock. So that's why the patient is going to another institution. So they can also write morphine is out of stock, and we have provided the medication.
Okay, thank you.
We should also ensure that a patient is not taking it from 2 places. It actually falls upon us. to check whether he's also taking it from some other hospital becomes very important, because it sometimes happens.
Yes, that's also very important. And we don't have any system to see whether this patient is taking any essential narcotic drugs from any other institution, because pharmacies are not connected. So I think we can wind up the session for today. We will have more idea on this in the coming session on opioid availability. And okay. So thank you, Rondo, for enlightening us with how to start a palliative care service if you are interested. And if anybody has any doubts regarding anything about how to start a palliative care service, our state facilitation team is always ready to help you with. And Rondo is the representative of Northeastern State, and you can call him anytime. Thank you, Rondo, for that excellent session. And
Thank you so much.
thank you all for your active participation. And I'm sure there will be more questions, but that will be answered in the next class. So thank you. Thank you, everybody.
Thank you,
Over
everyone.
to
Good night. Good night,
Priya.
everyone.
Thank you everyone for joining in. Thank you, Ron, for joining us and giving us a very useful insight on how to organize palliative care services for those who are interested. And so, with a just gentle reminder that tomorrow also we'll be having a session, the postponed session on DSM. This is Sri Priya, along with Mr. Rontu Sangma and Dr. Sunil Kumar signing off from the TIPSECO Hub. See you tomorrow again, same time. Till then, everyone, take care. Bye-bye.